So thank you for the introduction. The title of my talk is Deep Learning for Cardiovascular Image Analysis. So as we know, the number, the size, and the dimensionality of medical images is rapidly growing, and these images contain more and more data. Current visual expert analysis in clinic of medical images is very time-consuming, and therefore it is expensive. And due to visual fatigue, it is also error-prone. And a couple of weeks ago, there was a study in radiology that evaluated the effect of shift schedule and volume on interpretation accuracy of the images. And the authors have found that indeed longer working hours and higher workload are associated with increased risk of interpretation errors. So people get tired, but computers don't get tired, and therefore computers can potentially extract more information more reliably and more accurately. So in my group, we have been working on cardiovascular disease as one of the main topics. And cardiovascular disease is leading cause of death and disability worldwide. And cardiovascular events, either fatal or non-fatal, like heart infarction or stroke, are often the first manifestation of presence of cardiovascular disease. Nevertheless, subclinical signs, so signs without symptom of the presence of cardiovascular disease, are often visible in medical images as requested, or more often as actually unrequested finding. And in case of unrequested findings, current clinical workflow that requires manual expert analysis allows only limited routine detection of them. I think coronary artery disease is a good example of such a disease. It is a type of cardiovascular disease that is caused by plaque buildup in the coronary arteries. The plaque can be calcified or non-calcified. Each carry a risk of a cardiovascular event. But coronary calcifications are important because their amount, which is called calcium score, has been shown to be a very strong and independent predictor of myocardial infarctions. And calcium calcifications in the arteries, they're visible in CT scans that visualize the heart, and they're shown as high-intensity lesions, like here shown with arrows that look like a bone pattern in the arteries. But we know that atherosclerosis is a systemic disease. So that means that if there's calcification in the coronary arteries, there are likely calcifications elsewhere. And extracoronary calcifications, like those in the aorta and in the heart valves, also carry increased risk of cardiovascular disease and all-cause mortality. For example, calcifications in the aorta, in the aortic arch, have been associated with the risk of ischemic stroke, and calcifications in the heart valves may indicate problems with cardiac function. And they are visible in the images that show the heart, but nevertheless, only coronary calcifications are standardly reported, probably because of their very clear clinical relevance. So Nicholas Lessman, a PhD student in my group, proposed a method that can automatically detect and quantify calcifications in the coronary arteries, in the aorta, in the aortic and mitral valves. And we have developed a method with the scans that have been acquired in National Lung Cancer Screening Trial. So this is a US trial where the images are made for detection of lung cancer and not for the detection of cardiovascular disease. But follow-ups has shown that as many subjects, as many mortality cases in NLST were caused by lung cancer as by cardiovascular disease. And NLST includes heavy smokers who are at increased risk of lung cancer because of smoking, but also therefore at increased risk of cardiovascular disease. So we had a large set of almost 1,700 low-dose chest scans, and we have annotated all scans manually to provide us a reference standard. Those were calcifications in the 3 coronary arteries, left and right coronary artery and circumflex coronary artery, aorta, aortic, and mitral valves. And manual annotation in relatively easy scans took 5 to 10 minutes. And in difficult scans, it would take up to 90 minutes. Difficult scans were those where there is a lot of cardiac motion present, and there are a lot of, the noise levels are high. Due to low radiation dose, and this indicates that such analysis cannot be easily done in a large set of scans manually. So Nicholas proposed a method that consists of two subsequent convolutional neural networks. It takes a low-dose chest scan as input, uses large receptive field to be able to identify calcifications, atherosclerotic calcifications among all high-density voxels in the scan, and also to label them according to the anatomy. But because of the acquisition protocol, this has resulted in many false positives that resemble calcifications and are in the locations that could potentially be atherosclerotic calcium. And therefore, another CNN was used that has a small receptive field as input and was actually trained to be false positive reductor. So the results have shown good performance. Sensitivity in voxel detection was high, false positive volume was clinically acceptable, but results have also shown that we have very high accuracy for detection of calcification in the aorta and coronary arteries, but lower for aortic valves and mitral valves. And this is probably because, first, these lesions appear much less frequent in the images, and also because of the scans that are not dedicated for analysis of the heart. It is very difficult also for experts to annotate them. And there can easily be confusion between calcium in the mitral valve and circumflex artery, aortic valve. We don't see valves, we only see calcifications. So depending a bit on where they are and what shape they have, they can be confused with calcium in the aortic wall. For clinic, it is important whether we can assign each subject to risk category. So the amount of calcium score, determines the risk in a subject. So that could be low risk, intermediate risk, high risk, or very high risk. And 90% of subjects were assigned to the correct risk category, and reliability of this risk categorization was 0.91, so excellent. And this indicates that such a method could be used in screening. Okay, so in this work we have performed segmentation of all the calcifications, and thereafter we have quantified them and assigned subject to risk. And this segmentation is important if we have clinical patient data. If we have follow-up data, we want to maybe look at the progression or regression of a disease. It is also important for research, so we can investigate characteristics of calcifications with the disease. But in screening, maybe we don't need all these segmentations, and maybe instead we can just perform very fast risk categorization. So Bogda was investigated whether we can score these scans without intermediate segmentation. And he took a set of scans from the same data set and designed a network that is a VGG net-like, and performed regression instead of classification. So instead of classifying each voxel as calcified or non-calcified, the network regressed the calcium score. And then we have seen that this network was also very accurate, and that accuracy of CVD risk categorization was a bit lower, but reliability was almost the same, excellent. And the advantage of this method is that it takes only 2 seconds per scan. So this means that this method has a potential to be used in a very large set of images very quickly. We also were interested to see where this network gets the response. So we trained it with Agatston scores. The network generated other Agatston scores, predicted other Agatston scores. But we wanted to know whether this response is really coming for calcifications in the coronary arteries, or it may be coming from somewhere else. So Bob looked at this, and then here you see highlighted in red where the response comes from. It was indeed calcification in the left circumflex artery, or left anterior descending artery, and although there are 2 calcifications in the ascending aorta, they were not important in decision making. Okay, so what I've shown so far was analysis in low-dose CT images, and in clinical routine patient analysis, a high radiation dose is used. But reduction of radiation dose is generally desirable. However, low-dose acquisition leads to image noise, and image noise is especially not good for detection of cardiovascular risks for calcium scoring. And currently, scanner vendors provide an opportunity or provide an algorithm to acquire image at low dose, low radiation dose, and generate image that resembles routine dose image. The downside of this is that the algorithm requires projection data, which is not for us easily accessible, and it also takes a long time. So Elmer Woltering proposed a method to generate routine dose images from low dose images using image analysis. So the most obvious approach for this would be to take low dose image and use convolutional neural network to generate or estimate routine dose image. The problem with this is that such image generated in such a way is blurry, which is doesn't look very convincing, doesn't look very natural, but it is also really bad for calcium scoring. So, in addition, in the training we would like to compare this generated estimated routine dose CT with real dose CT, routine dose CT, but those are two different acquisitions. So we don't have really pixel performance. So actually we cannot train it so easily. And then we took a set of real routine dose images and added a discriminator to this, which had to distinguish between estimated CT images from real routine dose images, and trained the network this way. So we had again architecture. And we tested this in a set of scans of cardiac phantom and of patient CT scans. For each of these, we had the routine dose image. And the low dose image, actually, this low dose image was made with only 20% routine dose, so it's an extreme dose reduction. And we compare the performance of our algorithm with iterative reconstruction that is provided in this field scanner. So here you see the results for the phantom. On the left side, you see a low dose image. And on the right-hand side is a routine dose image, so two different acquisitions. In the middle of the phantom is a calcification insert, and you see intensity profiles for each of these scans in the bottom. So we see that low dose image is quite noisy, and then we first tested how CNN would perform, because we could train this easily. We had pixel correspondence, there is no motion, there is no cardiac motion. Images can be acquired one after the other, and they're perfectly aligned. But as we expected, we do see that this image is a bit too smooth. And then we tested our GAN approach, and we see that it resembles routine dose image much better, and iterative reconstruction actually as well. And then we looked at real cardiac CT scans of patients, and we wanted to perform calcium scoring. So here you see low dose acquisition. On the left side and on the right side are all in black all voxels that are potentially calcium, so high intensity voxels. And in red is the result of the calcium scoring as done in the clinic. So that's with 3D region growing. This scan is very large, has 500 slices. But when we do 3D region growing, basically we see that we cannot perform calcium scoring. Everything is connected in bone structures. Then we looked at again, and then we see that we can perform here calcium scoring. There is a bit of noise in the image, but it looks nice. And iterative reconstruction is very similar. There is a bit more noise, but calcium scoring can be performed well. And then we compare this with the routine dose image, which is different acquisition, and we see that what we have obtained with GAN and with iterative reconstruction is very similar to this. So in our set of 28 patients, calcium scoring was feasible in only 19 patients where we used this low dose scan. And when we used GAN and iterative reconstruction, it was possible in 25 out of 28 patients. And note here that this radiation dose was here reduced by 80%, so it's really extreme, but I think even in these extreme images it is quite feasible. But if you go with the radiation dose a bit higher, it would probably work in all images. The advantage of our image analysis approach is that processing takes only 10 seconds per scan, and we are not dependent on the projection data. Another topic that we have been working on is detection of functionally significant stenosis. So when there's plaque in the coronary arteries, either calcified or non-calcified, a lumen is narrowed, so artery has a stenosis. And this stenosis may cause problems in blood supply to cardiac muscle, to myocardium. Only the stenosis in which this happens, which we say functionally significant, that should be treated, and others not. So the grade of stenosis can be very well determined on cardiac CT image, so non-invasively, but to determine FFR, so to determine presence of functionally significant stenosis, patients have to undergo invasive coronary angiography with fractional flow reserve measurements. And the problem with this is that CTA is very sensitive, but it has very low specificity. So this means that some studies show that even 50% of the patients undergo invasive FFR unnecessarily. So many groups have investigated whether we could determine FFR, virtual FFR or FFR from the CT directly. And typically researchers have modeled blood flow through the coronary arteries, investigated, analyzed coronary artery tree, morphology of the coronary arteries, and recent studies have also used feature engineering to determine whether there is a perfusion defect in myocardium. We have used a bit different approach. So Marc took a CTA image as input and analyzed myocardium and only myocardium, no coronary arteries. So he first segmented myocardium using convolutional neural network to get a region of interest. And thereafter, he characterized myocardium using convolutional autoencoder. So we don't know what features exactly are predictive of a perfusion or show that there is perfusion in the scan. So we then use these encodings, or we computed their statistics and use them as a feature to identify patients who have functionally significant stenosis using support vector machine classifier. And we had a set that was very balanced, not large, 64 positive and 62 negative patients, and the area under the RC that we have obtained was 0.74. So this is a very promising result, and we think that in combination with clinical evaluation of CT scan, CT angiography, visual evaluation, and our method, we will increase specificity a lot and reduce the number of patients that undergo invasive analysis. Okay, so far I have shown cardiovascular analysis of cardiovascular images in CT scans, but MR is very important in the analysis of the heart. And at last MICAI, there was a challenge that had two goals. First was to perform segmentation of cardiac structures. So this is, I think, to mimic clinical workflow to determine ejection fraction from the segmentations. And thereafter, the second goal was to classify patients into 5 risk categories. And the challenge organizers provided a set of pairs of images at end diastole and systole, so the beginning and the end of cardiac cycle, and this disease, 5 disease categories, and we would have ideally wanted to analyze the images and predict the disease, but the data set was quite small. So we actually then also use what is done in the clinic. We segmented left and right ventricle and the myocardium using convolutional neural network that takes both images as input. And from the segmentation, we have computed features, quantitative indices that describe this segmentation, including ejection fraction and volumes as used in the clinic and some others, and patient characteristics that were available, and those were only height and weight of the patient, so no clinical information. And we used random forest to assign patients to one of the diseases. We have seen first that the analysis was very fast. It took only 5 seconds per scan to detect the disease. Accuracy was 86%, so quite high. But what we have seen is a major confusion between dilated cardiomyopathy and heart failure with infarction. And I think this is because in clinic, diagnosis is never made between these two diseases based on the images only. They show similar characteristics in the image, but to discriminate them, patient data is needed, real clinical data and patient data is needed. Okay, and then finally, we have looked a bit into multitask analysis. This is not really directly related to cardiovascular disease, but we were interested whether a single architecture could be used to perform different segmentation tasks, or actually wanted to know whether one trained network could perform multiple medical image segmentation tasks. And we thought that it would be interesting to have a system that would be coupled to a scanner, and it may be agnostic to the type of the data that comes in, but would still perform the task that has to be performed in those images. So Pim Muscops and Jelmer Woltering worked on this, and they took a set of MR scans of the brain, where the tissue classes, brain tissue classes were segmented, took CT angiography images with coronary arteries segmented, and breast MR with pectoral muscle segmentation. And they have basically trained the network with all possible combinations, starting from the representative data for each task, and then mixing in the end all the training data together and performing the segmentations in all images. And I will just show one result, which is representative. We have seen that there was no really very large difference in the performance if we train the network with the representative data or if you mix all together and perform the segmentation. So the performance remained quite equivalent. Okay, in the end, I would like to say a few discussion points. We work in a hospital and we have relatively easy access to medical images. But obtaining large sets of well-described data is a very challenging task. And with well-described data, I mean high-quality expert annotations that are associated with these images, diagnosis of the patients, outcome, long-term outcome especially, patient data, clinical data, lab data, all the data that is acquired somewhere, but it is very difficult to have a set that contains n images and all these variables. And in my experience, it limits us in the development. Another thing is, I think we have all seen, it's obvious that medical image analysis has been influenced by the developments in natural image analysis and computer vision. But specific to medical images is handling of high dimensionality data. All the images that I have shown have been 3D or 4D, but they can also be 5D. And we can likely in the future, hardware developments will enable us to use this high dimensional data easily or easier. But in the meanwhile, I think we have to work on algorithmic solutions to alleviate the problem. And I think that for medical image analysis, domain knowledge is really important. We need to know disease that we are investigating. We need to understand what information is in the image and what is not. And we also need to understand, I think, image acquisition protocol. So I would like to thank all my PhD students and Max Viergever, head of the Image Sciences Institute, and colleagues from the radiology department without whom I couldn't do this work. And if you're interested to see what we are doing a bit more, you can look at our website. And at the end, I would like to announce that we are organizing the first international conference on medical imaging with deep learning. It will take place in Amsterdam from July 4th to 6th. The website is now online. It doesn't have much information, but we expect to have a call for proposals by the end of the month. Thank you.